We shall go on to our first debate with Dr. NAMRATA Sharma, debating on the management of grade 5 chemical injuries with AMG. And she is going to be challenged by Dr. Geeta Iyer, who would profess as to why allosled would be the way to go. On to you, Dr. Namrata.
Thank you, Chitra. Thank you for this wonderful program, and thank you for making me a part of it. I'm going to speak to you about a topic in which actually there is no debate. I mean, I don't know how Geeta agreed. I mean, I'm sure if I was, in Geeta's shoes, I would have never agreed to do this debate. Of course, not from my side, but from her side. Can you see my this thing? Is it visible?
Yes.
So AMG in severe acute ocular chemical injury. So why AMG in severe acute chemical injury? AMG in moderate to severe acute ocular chemical injury should have been the name of this debate, but doesn't matter. I will still be able to defend it. And my worthy opponent is none other than Dr. Geeta Iyer, who launched a national campaign to prevent corneal blindness due to chemical injuries in the presence of Mr. Venkaiah Naidu, you can see, and Geeta, who's moderating the entire session. And I really don't know how, despite doing such a great program, she could give in to a topic such as this. We all know that tuna packets for us is the most common cause of injury, and I think Geeta should not get confused with other ocular injuries which are there in the Western world, where her philosophy or her thoughts may apply, but not here in India. And this is the tuna packet in Indian scenario. And way back means way back in 2006, we published this in ophthalmology that tuna packet is the most common cause of acute chemical injury. And although I know that people are still stuck up, some people and some studies are still stuck up to the Roperol classification, but I think what we need to look at is Dua's classification, because Roperol classification mixes up the Dua's classification of grade 4, 5, and 6 into just grade 4. Medical management, I think we all know, and there is no debate about it at all, that you have to act immediately and smartly and remove all the foreign bodies and irrigate as much as you can and sweep the fornices with a glass rod. And in the early acute phase, you have to give topical antibiotics, steroids, ascorbate, citrate, acetylcysteine, cycloplegics, oral vitamin C, anti-glaucoma drugs if required. And there is no doubt amniotic membrane transplantation is advocated for moderate and for severe cases of chemical injuries. For mild cases, perhaps you will not need, because that lipid on its own, but moderate and severe, you would need. And more importantly, you would need to remove all the necrotic material and all the tuna material and all the chemical that is there present inside. Now, there's so many advantages of amniotic membrane in acute burns. I do need not emphasize more on it, because even when Geeta does Eloslet to do it, she puts amniotic membrane, and I see no reason why explants from a allo source should be put, over there and increase the antigenic load of the eye. An eye which is already inflamed, an eye which is already hot, an eye which even kills the patient's own limbal stem cells, and over that you are giving an added burden of accepting the immunologic load of another allograft. So I don't think it is the time to do. And sometimes it's always good to wait for some time. And amniotic membrane is something which is very easily available. It is available, it's commercially available. You don't have to go running for it. In hospitals it is available, not something like allograft, where you do need cornea all the time. And when these kind of chemical injuries, they occur in peripheral hospitals or district hospitals or even medical colleges, or referred to patients, or even with clinical ophthalmologists, amniotic membrane is something that is there in everybody's armamentarium. So this is just to show that you just remove everything that is there, tuna, every bit of tuna, every bit of chemical injuries, and you put the amniotic membrane as has been classically described, not only on the surface, but also on the lids, the upper tarsus and the lower tarsus. And we have shown way back in 2005 randomized control trials, at least 6 of them published from our center. And although the initial trials had all grades of injuries, the trial subsequently had cases with moderate to severe burns, and it showed that it gave faster epithelialization, because our aim is epithelialization and not looking at the symblophron or the other things, limbal stem cell deficiency, etc., which again, even with the LO-SLET, they are not any less. So we did show that there's improvement, and this is a randomized control study which was published in American Journal of Ophthalmology, looking at 45 eyes. And before that, we've already seen in almost 200 plus eyes the effect of amniotic membrane. And in this, the amniotic membrane was far better as compared to the medical therapy alone, whether you see in terms of time to epithelialization, or you see decrease in the percentage of limbal involvement, or you see in terms of symptomatic relief. I think that is the most important thing. When patients are so devastated, that symptomatically also they should be relieved. And again, likewise, you can see here that all the values are significant. This study, of course, did see the role of cord serum also, but amniotic membrane was seen to be much better than the medical therapy. And this is with the standard treatment. This is when you do give amniotic membrane transplantation, and notice the corneas are much clearer. And this is, of course, with the cord serum. And we looked at a very unusual cohort of 31 eyes of the patients who fell into the ditch. And this will be the largest cohort which has been published and which has been followed up. You can never get a single cohort of 31 eyes, sodium hydroxide, time to presentation 1.5 days, and monitor each and every of these patients. And we've again found that amniotic membrane transplantation is the only thing that is required in these cases as far as the acute process of the injury goes. Now, there are two goals whenever you're doing this. One is surface stability, which is given by amniotic membrane transplantation, and the second is visual rehabilitation, which is given by SLET. And our stalwarts of SLET are sitting here, and I mean, with due regards to Dr. Sayan Basu, Dr. Virender Sangwan, Dr. Vikas Mittal, Dr. all the members of our ocular surface group. I mean, I don't have to, even show this. And if you've already done an amniotic membrane like this, it is so easy. The pannus is just waiting to be stripped off from there. The cornea is so clear, and then you can just put the amniotic membrane and put these little explants there. You can do auto SLET. This is auto SLET, and give very useful vision to the patient in the post-operative period. So it starts to clear up. And this is my very good friend, Dr. Vikas Mittal, who's also here and who's shown very nice epithelialization of the ocular surface. And if from here you come to here with a visual acuity of 6/6, why would you want to do anything else? I really don't know. And again, likewise, if you come from here and the patient's post-operative picture is like this, I don't think there is any contest that you can do amniotic membrane and then later on do a surface procedure while taking time or buying time. And if you have a pannus like this, again 6 months, and then 1 year, and then again 3 years. Now look at what the literature says. 63 articles on 63 articles on acute chemical injury, and 3 articles only on LO-SLET, and all 3 articles by our good friend only Geeta Iyer and only Shankar Netrale. And that too retrospective, none of them are prospective. And look at this multicentric trial. I mean, I think from every corner of the world, you can see a name here where, it says very nicely that if you wait and do SLET, the results are so good. The results are to the tune of, 80 to 90% success rate, 70 to 83%, you can see here. So AMT first is a time-tested procedure with sufficient literature, with sufficient numbers, with multicentric experience, and a great follow-up. A follow-up that spans almost 15 years. So I don't know why we would want to do a procedure which has been done by only, one center, and which doesn't have that much follow-up also. And that too a retrospective study. Now, LO-SLET, this is a result of LO-SLET. Whatever you may do, this amount of haze, vascularization, etc., would be there. Not like that clear picture that I showed you. It became so clear even after just SLET. So problems with LO-SLET are that only availability of the donor cornea has to be there when you are planning it. Then the donor cornea has its own, stringent criteria: age less than 40 years, death enucleation time less than 6 hours, immunosuppression because it's allo. Now, if Geeta doesn't want to do immunosuppression, I don't know. But of course, SLET has rejection. And I'm sure Dr. Sayan and Dr. Virender Sagman would agree that SLET cases do have rejection. So I don't know why we want to risk a rejection and then again wait and then do a real, auto slit or do a slit later on or do a keratoplasty later on. So it's, to my mind, it is just one more immunologic load, in an inflamed hot eye, which is wanting to quieten, but Geeta is not letting it quieten at all. Instead, giving it more load of antigenicity, so that, it becomes even more hot. So, uh, rapid dissolution of she herself has reported may occur in the inflamed eye, and it might not provide sufficient time for limbal stem cell expansion to occur. And if you have to do ex vivo after a alloslet, the whole purpose is defeated. So I do not think that you need alloslet in cases of acute chemical injury. I think in acute phase, do amniotic membrane transplantation alone, see how it goes. Sometimes it might just clear up, sometimes it doesn't. So do slet. And with the surface procedure, you might be lucky. And if you're not, then you can do a corneal transplantation, a DAL procedure, or any such procedure, and do visual rehabilitation. So thank you very much for your kind attention.